our tonight's webinar. During the last few months, the SUA has arranged for many superb webinar. Tonight, I'm glad to welcome you to our new webinar entitled The New Concept in the Surgical of BPH. Tonight, I am pleased and honored to have with us a speaker who is interested in BPH. Our speaker tonight is from the city of CN Tower, the Raptors, who last year won the basketball championship and the Blue Jays, but most importantly, the city of hot dog stands. My God. I'm glad to introduce Dr. Dean, who is Assistant Professor of Urology, University of Toronto. He participated in developing the CUA guidelines for BPH. He's a principal investigator of aqua ablation and a leading expert on MIS for BPH. Dr. Dean.
Thank you very much, everyone. It's a great pleasure to be with you tonight. I'm going to begin by sharing my screen, and I think we're ready to go. So we're going to actually start, before I get into my talk, with a polling question, if it's possible. So if we could pull up the first question as we approach this new concepts in the surgical management of BPH. I would like you all to put yourselves in the shoes of being the patient yourself. And we're going to ask this question again at the end. So if you, a urologist, had BPH, which option would you select? Would it be a bipolar TURP, a laser PVP, resume minimally invasive, or would you go on medical therapy? So there are 93 of you. And if you can, we'll try and get as many options inputted here, and then we'll begin our lecture. We have about more than half of people. It looks like medication is leading the way. That's excellent. And perhaps your positions will not change, but perhaps they will by the end of tonight's lecture. So I'm going to let the poll just go down into the corner, and I'm going to begin my lecture here. And so thank you very much, Dr. Farsi, for the introduction. I'm Dean Elterman. I'm a urologist here in downtown Toronto at the University Health Network, University of Toronto. Did my training here and in New York. And this is our beautiful city here, and the three hospitals that make up the University Health Network, the Toronto General Hospital, Toronto Western, and the Princess Margaret Hospital. So let's get into what is BPH and how significant of an issue. Well, of course, there are millions of men, tens of hundreds of millions of men around the world who have BPH, and there is a significant cost associated with BPH as well. And when you look at the reason why men go to see a urologist, BPH is actually the #1 leading reason why men would go to seek care from a urologist. This is some very interesting data from the United States, but the ratios and proportions could probably be extrapolated to other areas like Canada or Saudi Arabia. And so if you look at the United States, they have 38 million men who have BPH pathology, but fully only one-third of men will actually become under the care and management of a physician. So that means 2/3 of men in your country, in my country, in every country are untreated for their BPH, and they're either managing their symptoms on their own, they're taking herbal remedies, or they're living and really suffering in silence. And when you look at the 1/3 of men who go to see a doctor, only half of them will go on to medical therapy. And then a bunch of them will be on watchful waiting, a third, and several will actually fail medical therapy. And this was a very surprising number to me, but only 300,000 BPH surgeries are performed in the United States every year. So that means there are 1.6 million men who were originally failing medicine who don't even get anything. And then, of course, there's a huge number of people who will progress as you are waiting. So the potential pool of men who are untreated, undertreated, or underdiagnosed is significant. And so this provides a great opportunity for us to really bring them into our practice, and perhaps the introduction of minimally invasive therapies that I'm going to talk about is an option for these gentlemen. A key thing when you're looking at management of male lower urinary tract symptoms, or LUTs, and this is from the Canadian guidelines, is to really look at each individual patient's symptoms and individualize their care. So look at the voiding symptoms, look at the storage symptoms, and decide, is this mostly bladder issues, prostate issues, and then what options are you going to present to men? As was discussed, the Canadian guidelines for BPH have been updated in late 2018. I was one of the authors. These guidelines are available online for free. And of course, the American guidelines and European guidelines have also just been updated, and they provide quite a bit of help and recommendations. And of course, everything that I'm discussing is on guidelines. So we have a number of medical therapies that are available. We're very familiar with them, but of course, with all medications come side effects. And not only is the difficulty to get men to take a pill every day, but it's also to put up with the side effects. And many men are very dissatisfied with the side effects of alpha blockers that we're familiar with the side effects of 5-alpha reductase medications that we are familiar with. And of course, even when we look at surgery, there are significant both short-term and long-term complications that may arise, anything from injury and bleeding to long-term issues such as urethral stricture and incontinence. And so there's a deep desire for us to find an alternative. When you look at the guidelines, the indications for BPH surgery are, of course, infection, retention, stones, hematuria, renal dysfunction. These are the big five. But you must also remember that symptom deterioration, despite medical therapy. And the last one, which is really important that we often don't pay attention to, is patient preference. And my personal belief is we spend a lot of time thinking about long-term consequences, infection, hematuria, and we don't stop to ask men, what would you prefer? And I think that if we introduce these minimally invasive therapies, increasingly men may prefer to choose these even over medication and completely switch the way that we do the treatment of BPH. So why do we desire alternatives to TURP? Well, if you look at this risk to benefit graph, you can see here that medications live down in the lower left-hand corner. They're somewhat beneficial, and they're also very low risk. On the other end of the spectrum, we have open prostatectomy, TURP, laser, enucleation, wonderful operations. They've evolved over time, high risk, high reward. And many men will be very happy to approach these, but some of them will have concerns about the increased risk profile relative to the benefit. And so this is where we come into this new middle ground, which is these minimally invasive surgical therapies, or MISTs, M-I-S-T. And they really bridge the gap in terms of increased benefit over medication, perhaps approaching the benefit of a surgical intervention, but with a much lower risk profile and ease of use. And I think that is really what has been missing in the treatment of BPH. And so if I was to come up with a wish list of things that I would want a therapy that would improve symptoms. It would be easy and painless for both the patient and myself to perform. It would improve their symptoms in a relatively rapid time with a relatively acceptable and short recovery. It would be very safe. And of course, it would be durable. So that brings us to, how do we position these MISTs, minimally invasive therapies, compared to both medicine and surgery? Well, of course, as I mentioned, it gives an alternative to the medications. And as you remember from that 36 million, the greatest number of patients that are out there are on the medical side. They're not the men who are choosing between surgery. Remember, only 300,000 surgeries done every year. 12 million men, 20 million men in the United States are on medicine or not taking medications. And of course, that gives an alternative to many men who don't want to have traditional transurethral surgery. And you have to understand their individual values, both recovery, their anesthetic concerns, sexual function, and catheter duration. These are the types of things that will help us guide, and we'll talk a little bit later. So I'm going to first talk about the UroLift system, and then after that, I'm going to talk about the Resume system, and then some more general things. So as a brief review, the UroLift system, or the prostatic urethral lift, or PUL system, gained FDA approval in about 2014, 13 or so. And what this is it's implants placed in a transurethral fashion from the prostatic urethral lumen all the way to the outside of the capsule. It's performed endoscopically, And what it does is it compresses or squeezes the lateral lobes to make a mechanical separation or opening of the prostate. And for prostates, there are between 30 to 50 mils. We typically would implant 4 sutures or implants, and they're in pairs across from each other. It's a stainless steel and nitinol. And this is a single-use handpiece you can see here that's preloaded with 1 suture. So every time you put in one of the implants, you're going to change this handpiece over your lens. And this is a nice before and after picture. You can see that the implants are typically placed a little bit anterolaterally with the mechanical pulling open of the lobes. And what it does is it creates a channel mostly anteriorly. And of course, it's going to stay away from the inferolateral neurovascular bundle. And so you don't have any concerns with causing erectile dysfunction or pain. And of course, you won't be placing it straight up where the dorsal venous complex sits. There have been many studies reported over the last decades demonstrating its safety and efficacy. And it, of course, has been approved in Europe, in the United Kingdom, Canada, the United States, and now it's available in Saudi Arabia. There are published 1, 2, 3, and 5-year data demonstrating the durability of the UroLift system. We typically see the improvements initially around 2 weeks, 2 to 4 weeks. And where you are at a month is very similar to where you will be at 5 years. Now, the retreatment rate is something to note. We know that the surgical retreatment rate for UroLift is close to 14%. And when you add that up per year, it's about 2 to 3% per year, compared to TURP, which is about 1 to 2% per year. I'll even give you a contrasting then to the retreatment rate of Resume. So remember, UroLift retreatment rate is about 14%, and I'm going to show you in a few slides that the Resume retreatment rate at the same period of time is 4.4%. So that's one of the differentiators between the two. But certainly, UroLift is an excellent system that for the majority of men will have a very good outcome. Interestingly, when you look at quality of life, TURP does improve IPSS more than the UroLift, and it definitely improves the flow rate significantly more than compared to a UroLift is the TURP. But what's interesting is that despite not having a huge improvement in flow, say relative to a TURP, the degree of improvement in quality of life is the same. In other words, remember, we're treating a quality of life condition, and at the end of the day, if men are happy, that's pretty much the most important thing. And men are equally happy between a UroLift and a TURP. When you look at recovery, the light blue line here is the UroLift, and UroLift patients compared to TURP actually recover far more quickly. They feel more satisfied sooner and to a greater extent. And it really takes between 6 to 12 months for the TURP group to catch up. And if you ask those men if they're satisfied and whether they would do it again, significantly more men would endorse doing the UroLift again compared to a TURP. In terms of adverse events, they're typically very mild and self-limited to the first, say, 1 month. And those are typical things like dysuria, hematuria, a bit of pelvic pain or tightness, and some urgency. But again, there is no new incidence of ejaculatory or erectile dysfunction. So this is a sexual function preserving technology or technique. Initially, the UroLift was prohibited in men who had median lobes, and that was part of the FDA guidelines, and it was because they were excluded from the original trial. Over time, there have been adaptations to the technique, which allow for medium-sized median lobes to be treated with a UroLift. It is a little bit challenging. I have done it, and you can see here what you have to do is actually tack down the median lobe into the prostatic fossa and into the lateral lobes. And that's a diagram that shows it. And this was the MedLift study, which demonstrated the treatment of median lobes. And as such, the FDA labeling has changed recently. Again, this is for modest sized median lobes. In this study, they compared the outcomes of men who had lateral lobe obstruction only compared to those with median lobes. And if you're able to tack back the median lobe, you get just as good of an outcome compared to those who did not at all. And this is a nice picture of a before and after. You can see a fairly prominent median lobe. And the technique is you have to pull down and in the median lobe to the side that it wants to go to. And then you suture it and tack it almost downward, just below the horizon, so that it's pushed down and out of the way. The concern, and I would put a caution, is that you need to be careful at the bladder neck that your urolift suture does not go out into the bladder neck, because you can get encrustation and a stone formation. So it is a little bit tricky in terms of being able to place these median lobe urolift sutures. I'm going to shift over now to the second minimally invasive surgical therapy, or MIST, that is available in Saudi Arabia. This is the Resume Convective Radiofrequency Thermal Therapy Ablation. This was introduced at the Saudi Urological Association meeting back in March, where I had the pleasure to join you in person in Jeddah. And it was a great honor to be there and to do the first cases with you in KSA. So I'm going to go through Resume. This is a different type of thermal therapy. It applies energy to the lower urinary tract, utilizing a unique heat source, which is water vapor or heated steam. The way that the heat is transferred is through convection as opposed to conduction, and I'll explain what that is. And uniquely, it's contained within the prostatic anatomy, meaning it will stay in, say, the transition zone and not go through the pseudocapsule into, say, the central zone or the peripheral zone. So it's very safe. And what you end up getting is a convectively delivered, targeted, and precise dose of thermal energy. A quick video here is going to play on the right-hand side. On the left, you can see that the system is no more than a desktop printer. This is a single-use handpiece. It goes in using a regular 30-degree lens. You measure back from the bladder neck. Over 9 seconds, heat is transmitted from the needle. It transverses through the transition zone convectively, and the heat causes the cells to die, and thus it will shrink. And so you place these heat treatments consecutively from the bladder neck back to the viru, and you're done. Most of these treatments take about 2 to 4 minutes, let's say. And then over about a 1 to 3 month period, that tissue will slowly resorb and the prostate will actually shrink down. And I will show you some pictures about how that works. So what you're seeing here is this phase change where water goes into steam at 100 degrees, and you're taking all of that stored up energy and transmitting it into the prostate. And the magic number that you're trying to get is 70 degrees. So you're taking the 103 degrees steam with body temperature prostate. And when they mix at 70 degrees, that's where you get instant cell death. You get apoptosis, cell wall denatures, and the cells will actually rupture and die. And then slowly over time, those cells will be cleared away. Now, this is convection, and this is really what differentiates it from older transurethral technologies such as TUMT or needle ablation. The difference is that convection travels evenly through the cells, regardless of how close you are to the source. Conduction is more like the flame of a candle. It's much hotter at the source, but it dissipates as you go further away. And so you get uneven heating, and that's really why tumped and tuna have really fallen out of favor over a decade ago, because they really weren't giving a consistent result. Whereas convection really allows for the heat to transfer evenly all the way through the tissue. Uniquely, these are the zonal boundaries, and the steam will not transgress between the two zones. So if you're injecting into the transition zone on the left, it will stay in the transition zone and not go into the rectum or the bladder or the peripheral zone. So again, it's a very safe, targeted dose. This is an example of video that's going to play, which actually shows on the right-hand side, the Resume being lined up. And on the left-hand side, just for the purposes of demonstration, as an ultrasound. In the real world, when you do Resume procedures, you do not need an ultrasound. what this ultrasound image is showing you is that when the needle goes into the transition zone on the patient's right here, you will see the plume of steam being injected. It'll look white, and it's going to fill up the transition zone, but it will not extend beyond the transition zone, and it will stay very nicely in that lobe contained. And remember, it only takes 9 seconds for that steam to go in, and then you will move along to your next injection. And here is post-operative MRI scans that actually show what is happening to the prostate. You can see after 1 week, these lesions in the prostate that have been ablated. And 3 months later, you can see that essentially 97% or so of the lesion is entirely gone. And we look at this MRI data, we can see that the lesion is resolved by about 92% at 3 months, 97% by 6 months. The transition zone volume is going to shrink up to about just shy of 40%. And the actual overall prostate volume will shrink anywhere from 25 to 30%. So this is what you can expect to see in terms of reduction in prostate volume, specifically targeted to the transition zone, which is the most important area. Now, as I mentioned to you, the UroLift has been adapted somewhat to be able to do a median lobe, but it does pose some challenges. With a Rezum procedure, the median lobe is actually not a contraindication at all, and you are able to treat even very large median lobes. I'm going to run 2 videos here of the same prostate. It was measured to be 52 milliliters in volume, and it received 3 injections on the right lobe, 4 injections on the left, and just 2 injections on the median lobe. And you can see here, all of us have done cystoscopies and have noted very large ball valve median lobes like you see here. These are the types of prostates that are, of course, very refractory to medical management. They do very well with transurethral resection when you remove the median lobe. But here, after 2 steam treatments of the Rezum, 6 months later, you can see that that median lobe has entirely disappeared. And again, that will probably take about 30 seconds or less to do those 2 steam treatments. So this is a nice before and after picture. This is another cystoscopy, compliments of my colleague, Dr. Rijo in Spain, in Barcelona. He did a cystoscopy on his patient 10 months. And you'll notice here, this is after a Rezum procedure. It almost creates a TUR-like defect. You can see a preservation of the bladder neck, a little bit of necrotic tissue on the right, but a real cavity that's been formed in the prostatic fossa after, again, just using the steam treatment of the Rezum. I think that's a nice example of what you can expect. So the indications are to relieve obstruction, symptom improvement, and reduce prostate volume. It's on-label uses for 30 milliliters or grams or above. And of course, you could do hyperplasia of a median lobe and or central zone. The contraindications you should be careful are implants, such as an artificial sphincter or a penile prosthesis. There was a very large clinical trial prospectively performed. In fact, the 5-year data was just presented virtually at the AUA. This was a 2-to-1 randomization. I'm just going to summarize the data here. You can see that at baseline, the IPSS score is around 22, quite significant symptoms. By about 1 month, you'll see men have about a 50% improvement in their symptoms. And by 3 months is really where they're going to start to feel the much significant improvement, which will be very similar to where they will be at year 1, 2, 3, 4, and 5. So somewhere between 3 to 6 months when they reach a nadir or most improvement is very predictive of where they'll be. And you can see here a significant improvement in Qmax, which is sustained, as well as improvements in quality of life parameters. You can see here that they get better by about 1 month, really fully better by 3 months, and it's very sustained year in after year out. So the way I counsel my patients is to say, by about 1 month, you'll start to feel the improvement, and by about 3 months is pretty much where you're going to be. Now, in terms of not only quality of life, but sexual function, again, there are no changes in sexual function. The IIEF for erections remains stable and flat. It does not change. And in this clinical trial, there was actually no change in ejaculatory function on the MSHQ in all the domains that are measured. Also in this pivotal trial, they were given the option of treating a median lobe and not. And you can see here that in those men who had their median lobe treated, they did significantly better than those men who had a median lobe, but the investigator decided not to treat it. So the bottom line here is if you see a median lobe, you should treat it with some steam and they'll have a very good outcome. As I discussed with the UroLift, with Resume as well, the adverse events are fairly short lasting and mild, typically 2 to 4 weeks. 57% of the patients, in fact, did not have any adverse events. And also very similarly to the UroLift, you're seeing things like dysuria, a bit of hematuria, frequency, occasional retention, and urgency. And they're all, of course, self-limited. With the Resume, there does require a short catheter. You can imagine that the steam causes some swelling or edema of the prostate. In the clinical trial, the average catheter duration was 3 days. But of course, it can vary depending on how big the prostate is and how much steam is placed. For my UroLift patients, if they put in 4 sutures, I'll often leave them without a catheter. But of course, if it's 4 and they have a bulky prostate, or we put in more sutures like 6 or 8, then I will leave a catheter for a few days as well. As I mentioned, the retreatment rates are a little bit different than with the UroLift. You can see here at 4 years and as well at 5 years, which was just presented at the AUA, the Resume surgical retreatment rate is 4.4%, and it remains very stable at year 3, 4, and 5. And that's compared to the 14.6% of the UroLift. So some takeaways is that you do see sustained improvement. It's a very durable outcome with a very low, the lowest retreatment rate for a mist. Sexual function is preserved. You're able to treat a median lobe without any consideration or worry at all. And adverse events are very infrequent and mild. There was a nice comparison here that looked at the MTOPS medical therapy study compared to Resume. And you can see here that we all know that combination therapy is better than monotherapy from the MTOPS study. But in fact, Resume is even better than combination therapy when it comes to improving IPSS score. And of course, with medical therapy, you are going to see a percentage of men who will have disease progression. Whereas with Resume, you're actually treating the prostate and you're not going to see as much. And the big difference, of course, is that with medical therapy, especially dual medical therapy, there are significant negative impacts on sexual function, erectile dysfunction, ejaculatory dysfunction, decreased libido, whereas you do not have any negative impacts with the Resume on sexual function. I think cost is another consideration. It doesn't matter where you are in the world, hospital administrators, payers, doctors, patients, they do care about cost. This is a very nice table that came out of the Cleveland Clinic that shows the cost in dollars for 2 years and then the average improvement in IPSS along the bottom here. And you can see here in the red that medical therapy still has pretty high IPSS and a big difference in cost, whether it's generic or branded. But this is where the real story is. If you look at the difference in IPSS, TURP and Greenlight are within less than $100 of each other, and they're within maybe less than 1 point in IPSS. So I would consider them almost equivalent. Then when you look at MIST, minimally invasive therapies, they're both in this between 12 to 10 IPSS range. So they're very comparable in terms of the degree of improvement, but you can see here on this axis, almost a 3 times higher cost of the UroLift compared to the Resume. So this is another comparison. They're both very effective, but there are cost differences between the two modalities. So looking at both of these procedures together, more as a general broad category, when I'm thinking about patient selection, who are we going to offer this to? Who are we going to speak in our clinics to men who have BPH? Well, obviously men who have elected to stop or who have chosen not to take BPH medicine. And I see this even more commonly now that men are going onto the internet and they don't want to have finasteride, they don't want to have retrograde, and they actually say, I don't even want to go on medicine. What else do you have to offer me? Of course, there are men who are not receptive to other either minimally invasive or BPH procedures. And so that's the other end of the spectrum, men who want to avoid surgery. And then, of course, there's another group that's men who are starting to become symptomatic, but they're really not bothered enough to say, want to go on a pill or want to take drugs. So again, it's that risk reward benefit, that ratio or trade-off that you're considering. When I'm looking at patient selection, one of the very important conversations that I have has to do with the assessment of expectations, patient expectations. What do they want? What are they expecting to have out of this procedure? The other thing is not to overpromise compared to TURP. Remember, these are minimally invasive therapies. Nobody, especially me, is claiming they are as good as a TURP. They're close, but they're not as good as. And so you don't want to tell people it's a replacement for a TURP, because it's not, but it is an alternative with some differences. The other thing in terms of expectations is also to assess values. What do men want? Do they want to go off medications? Do they want to avoid surgery? Do they want to preserve sexual function? You need to find out what is motivating them, and that will help you both have that conversation about how you're going to choose. The last thing I would say is there's no type of patient. I pretty much offer a minimally invasive therapy to every man who walks in the door. In addition to the conversation about medical therapy, TURP, green light laser, aquablation, all of the different things, but you have to put it on the menu to allow them to decide. And it doesn't have to be a young man. It doesn't have to be an old man. It doesn't have to be a sexually active man. There's no one type. So I think it's important to start to offer this broadly and generally to patients. When you're starting out to do these cases, there is a short learning curve, probably around 4 to 6 cases, not very many. I would encourage you to pick smaller size prostates, maybe less than 50 mils. And of course, prostates that aren't necessarily going to bleed. So non-catheterized patients, for example. Who are the ideal patients? Well, all the studies were in patients between 30 to 80 mils in volume. So it's very difficult to extrapolate outcomes if you're going to be going over 80. So you can, but the outcomes are a little bit unpredictable, or at least there's no study that you can point to. Even once you get into these large glands, and there are studies coming up, there will be an upper limit. You know, with the UroLift, it's probably around 100 milliliters because the prostatic urethral lift implant, the suture, has to reach the capsule. And if the prostate gets too big, it actually won't reach the other side. With a Resume, I think the upper limit is somewhere between 140 to 160 mils. And that's because of the number of steam injections that are available per handpiece. I think you need to be reasonable. I don't think it makes sense to have a minimally invasive treatment and put in 18 UroLift sutures or go through 2 Resume handpieces. I think that you're no longer a minimally invasive therapy if you're really pushing things over the line. So when I talk about patient selection, I would say almost everyone is a candidate, and we'll talk about who is not a candidate coming up. Those who are naive to medications, that's fine. Maybe they don't want to go on meds. People who are on meds and want to come off, men who are progressing and getting worse on medications, or they're unhappy with medical therapy. The patient selection, I think you need to pick a volume that's, to your comfort that you can treat and what's reasonable. So the number is somewhere between, for sure, 30 to 80, probably 30 to 100. And when you get very comfortable, you could probably push it a little bit higher. And of course, you need to consider the anatomy, specifically the median lobe. If you are doing a Resume, I really wouldn't worry about it because the steam will be able to treat it very easily. But if you're considering a UroLift, you should know how big the median lobe is, and you have to know how to do that technique to pull it in and out of the way. Pain medication. I think I'll take a quick side note here. In the era of COVID-19, all of our healthcare systems have changed significantly. And the pressure placed on our hospitals and operating rooms is going to change dramatically over time. Maybe some of your other speakers in this web series have talked about it. And so the idea that we can pull BPH surgery out of the operating room, out of the operating theater, and perform it in another setting, like your cystoscopy unit, for example, or some sort of other medical office building, is very attractive. And so both of these minimally invasive options allow you to bring these procedures out of the operating room and into another setting. And even more so in the age of COVID, this will be important because there will be a lot of strain on our system to be doing stones, to be doing cancer. And so when we look at the type of anesthetic or pain options, it depends a little bit on your setting. We can, of course, give just oral anxiolytics and oral analgesia, some xylocaine gel in the urethra, and you could do a urolift or resume. Of course, if you felt comfortable, you could do a prostate block, transrectal ultrasound guided block, or you can even give IV sedation. We do a lot of these under just propofol sedation, like a colonoscopy. So I think your choice of anesthesia really depends a little bit on your facility, your level of comfort, as well as your patient's level of comfort. I think oral sedation with xylocaine is very possible to do. IV sedation, if it's possible, is very easy. If you can bring an anesthesiologist down to your cystoscopy area, give them a little bit of either propofol or midazolam, it'll work very well. And of course, prostate block. One thing that we have been using here in Canada, and I am aware that this is available throughout the Middle East, is something called Penthrox. So I'll bring your attention to this. It's called methoxyflurane. This is an old inhaled fluorinated gas from anesthetic machines, but we don't use it anymore in anesthesia because it gives complications of renal toxicity. But at a very low dose, 1/1000th of the dose, is being approved for surgical pain. So paramedics, ambulances in Europe and Australia carry this for trauma, for car accidents, for fractures. We've just finished our first pilot series of 12 patients getting resume in Urolift with Penthrox, and it worked exceptionally well with pain scores around 2 out of 10. So I would encourage you to look for that. In terms of pre-treatment planning, I think doing a cystoscopy is helpful, especially if you're considering between resume or Urolift. You want to know about the median lobe and the angle. I am a big fan of getting an ultrasound volume assessment of the prostate beforehand. All of the guidelines are based on volume. And so I think a cystoscopic evaluation or a DRE are insufficient to really know the true volume of the prostate. Now, if you do a cystoscopy and it looks medium, moderately enlarged, you're probably fine, but you should at least have a sense of how big that prostate is, because the last thing you want to do is plan a minimally invasive therapy and realize that it's just too big. When you do the resume procedure, you want to have these overlapping lesions. So the steam will travel about 1.5 to 2 centimeters. And so you're going to place each steam injection about 1 centimeter apart so that these zones of ablation overlap each other. They're contiguous. And so you're going to measure 1 centimeter back from the bladder neck. And of course, you will stop at the vira montanum. So all you're trying to decide is how many injections and where to place them. This is an example here of the video showing you how to move and measure the prostate. On the left-hand side, you'll see there's this distance between the end of the scope here and an imaginary line that goes between the two arms. And that distance is exactly 5 millimeters or 0.5 centimeter. So what you want to do is when you're moving, say, 2 fields of view, that's 1 centimeter. So now you can draw your attention back to the movie. You can see he's moving back 0.5 centimeter, 0.5 centimeter, 0.5 centimeter, 0.5 centimeter. And so that's how you plan out how to move. With the median lobe, you want to angle usually about 45 degrees and come about 1 centimeter back from the top of the median lobe. And so I'm getting to the last 3 or 4 slides here, and then we'll open it up for discussion with our moderators. So I wanted to discuss how do I differentiate resume from both pills and other minimally invasive techniques in surgery, and then I have a slide for Urolift. So with resume, it's a one-time treatment. It can be done with light sedation, a local
We lost your screen, Dr. Dean.
Screen. Thank you. Are we back? Yes?
Yes.
Thumbs up, great. No pain. It's natural water-based. Some patients don't like to have an implant, something foreign in their body. It does have the lowest retreatment rate compared to other minimally invasive therapies. It has essentially no ejaculatory dysfunction. Median lobe is not an issue, and there's a very wide range of volumes with that single handpiece, which comes into the economics of it. When we talk about UroLift, again, it's a one-time treatment. It can be done with even some light sedation or local anesthetic. There's no pain. It's a very small implant. It can't be felt. Men will not be walking around feeling that they have something in their body. There is no ejaculatory dysfunction at all. I think the median lobes are less of an issue now, but of course you need to know that technique and ensure they're not too big. And it does have a shorter catheterization time, which may be a factor for some men in the very short term. So when you're talking to patients, I would say, remember, understand BPH, understand all the options, consider everybody a candidate. When you're talking about medicine, when you're talking about TURP, add this to your menu, add this to the repertoire of things that you will discuss with patients. I don't think everybody can offer both UroLift and Resume. You may end up choosing the one that you feel more comfortable with. But again, I think you have good options in both. I spend a lot of time with my patients explaining to them the procedures, the pros, the cons, etc. I think cost is only one factor, but of course you should be transparent and of course be fair and balanced with them. Some last tips and tricks. So in Resume, I think, again, setting realistic expectations is very important in the short term and the long term. I tell men that their symptoms will get a little bit worse for their first couple of weeks before it gets better by about week 3. It's very important to introduce the scope carefully and slowly so that you don't cause a false passage or split the prostate. I like to not move around too much and do extra measuring. I really try to keep my hands very still and level and aim the needle at the bulkiest part of the prostate, which is different from a UroLift, which is higher up on the prostate. And I always know in the back of my mind, in the corner of my eye, where is the sphincter, where is the viru? And of course, if the patient moves, just be very still. For the UroLift, again, set those expectations ahead of time. Let them know what the retreatment rate is. The lens that is used for a UroLift is not a standard lens. It's an extra long and an extra thin lens, the optics. So you would actually have to order in an extra long 3 millimeter, not 4 millimeter lens. So it's special equipment that you need to order in. It can very easily break. It's more fragile. So as you're putting it in and out of each of those UroLift implant, you have to be very careful. Again, don't look around too much. Don't put the implant in too close to the bladder neck or you'll get a stone. You always want to keep your hands level, but up toward the top third of the prostate. You do need to compress the tissue sufficiently. With a Resume, there's no compression whatsoever. With a UroLift, the whole point is that you have to squeeze the tissue together and then deploy the implant. It's very important when you're pulling the triggers that you do them in the proper sequence. Otherwise, the implant could jam and get stuck. And again, always know where your viru is. So I think this is almost my last slide. Remember to be honest with your patients, know the data, set those expectations, understand their values, understand what they are trying to achieve. Work up the patient properly, know how big the prostate is, do your cystoscopy, understand whichever technology you're going to be using because it'll allow you to get the most out of it. And of course, understand the anatomy and follow a plan. The last important question is who not to give a miss to, who not to offer this to. So in my opinion, I think a large atonic bladder is not a great idea. It's unlikely to work. Of course, if it doesn't work, you could always fall back on a simple prostatectomy, a TURP, or just having them catheterized. These very large capacity bladders, which I guess is a bit more of a detrusor underactivity, you should have some caution, or at least counsel them that it may not work. If their prostate volume is very large, 130, 140, 150 mils, you're going to reach a point where the technology is not a good idea. It won't do what you want it to do. If they have an enormous median lobe, maybe all the steam in the world won't get rid of it. And they might be better with just a resection of the median lobe only. Patients with significant renal impairment, again, I think you want to be cautious. You might want to offer them something more disobstructing. for Resume specifically, anything that's going to require more than 15 injections or treatments, because there is a limit to the handpiece. And with a UroLift, of course, something that's either too long or too large with a median lobe, or very massive in volume, bigger than 100 mils, it may reach the capacity that you can really effectively do it with a UroLift. So this is our setup. This is in a medical office building. It's 15 floors up downtown Toronto. You can see here my nurses, my fellow, my assistants, and we're just doing these first cases here under some light sedation. This is me being very happy. You can see here a nice uroflow. This is a patient who went from a baseline Qmax of 2.5. 3 months later, he was at 22 mils per second. So it really does work. I think offering minimally invasive therapies are a great option to have in your urology practice. They offer men so much more variety and choice compared to medicine, compared to surgery. And I think that I'm looking forward to our discussion now. I'm going to stop sharing my screen and hand it back to our moderators, Dr. Farsi. And we have some follow-up questions and a discussion. So again, I'd like to thank the 160 odd participants who have joined us this evening. It's my great pleasure to be with you. Thank you very much.
Thank you, Dr. D. Can you put back the question that I put at the beginning of the lecture to see how did your lecture influence the audience? Right.
So everybody can vote again, and let's see if you would do the same. I think at the beginning, if I remember correctly, most people were leaning towards actually having medications.
That's right.
Yeah, so as the last couple of votes come in, I see here, Dr. Farsi, you can agree, and the other moderators. I think now that we know a little bit more about the myths, I didn't include UroLift, but I think let's just consider this minimally invasive compared to TURP, PVP, and medication. It's nice to see that there was a bit of a shift in our audience. So that's very interesting.
Well, obviously you convinced them about this procedure. Now, my colleagues, Dr. Alaskar and Dr. One of them have cases or something? Dr. Alaskar?
Well, actually, I have some points regarding the topic. First, an excellent presentation regarding the UroLift and Resume. And actually, this is what we need as urologists, something alternative to medications, because we have some patient, they come to the clinic, they don't want to have the medication, but they want something done for their prostate. I'll just divide my question first on the UroLift. Us as a urologist, we're very reluctant in inserting foreign bodies inside our urinary system. So from the study, they showed around like 6 years experience of UroLift. So my question is, the risk of incrustation, stone formation on the long term, is there any like age limit? For example, patient is 50 years old, would you recommend UroLift for him? What's possible complication at the age of 70? And if he has complication, if he needs a TURP, what will be the approach? What's the precautions if you want to do a TURP, for example, regarding the implants or so? So this is my first question to Dr. Elterman, so you can comment on them.
Thank you. So I think that when the UroLift sutures are placed properly inside the prostatic lumen, it will impinge and pull back on the prostatic urethral lining. And over time, the sutures actually get covered by mucosa. So you really should not see formation of a stone inside the prostate. Now, if the sutures are placed close to the bladder neck, you may have seen that they come out on a little bit of an arc. And so if you are too close to the bladder neck, it will swing out as an arc into the bladder and then come back, and you'll almost get the shoulders of the bladder at the bladder neck. And it's there where you can get encrustation and the formation of a stone. And then in terms of complications down the road, so you could do a TURP or a radical prostatectomy or a laser after having had a urolift. You would essentially just cut through the suture and the little metal part will become free and you can irrigate it out. Now you will not be able to get the second part of the metal, which is on the capsule on the outside of the prostate. There's no point to retrieve it. So it is possible to do a repeat surgery down the road. And there's no age. I think there was a question about age. I wouldn't consider a specific age cutoff. In fact, again, I don't want to paint all patients in a certain way, but obviously younger men, those who want to maintain fertility, for example, it would be very important. And of course, you know, with these minimally invasive options, specifically the urolift, they'll keep their ejaculatory function. So again, if you have a younger man who wants to have a family, these minimally invasive therapies are better than a TURP or a laser, where the rates of retrograde are between 40 to 80% with endoscopic surgery.
Well, thank you. So another element is the resume. Actually, you mentioned that the catheterization time around 3 days. Have you encountered difficulty in inserting catheter after doing a procedure for resume? And if so, you mentioned one of the options is in and out catheter for the patient until the patient is voiding freely. So if there is any difficulty in catheterization post-resume, what are the causes? What's your troubleshooting then?
Yeah, so I tend to just leave the catheter after I place the resume catheter at the end of the case. And based on the prostate volume, I'll estimate, let's leave this in for 3 days. Let's leave this in for 5 days. If they were in the minority of patients, less than 5 or 8% that have retention, there's no difficulty replacing or repositioning a new catheter because the prostate will still be pretty solid. It doesn't turn soft or mushy. A patient could absolutely choose to self-catheterize. I think just in the interest of comfort, it's probably easier just to put in a catheter, leave it for a few more days, as opposed to passing an in and out catheter several times through a freshly, essentially operated on prostate. In the United States, they were using these small catheters called the spanner, which is a small intraprostatic catheter. The issue, though, is that there were much higher rates of urinary tract infection with the spanner. So I wouldn't recommend the spanner, even if it's available in Saudi.
So one of the questions from the audience regarding prostate cancer, I think it's one of the contraindication to do it with the resume, if I'm not mistaken, or you still perform it for like a channel TURP?
Yes, so there's actually no contraindication to perform either urolift or resume in the presence of prostate cancer. There is a publication where they actually use the urolift implants as the fiducial markers for external beam radiotherapy. And additionally, we have done a lot of resume on patients on active surveillance. And in fact, another very interesting cohort is men who have prostate cancer who are awaiting brachytherapy, seed implantation, but their prostates are too big. And we've actually started to now offer them at the cancer center resume to shrink the prostate down, and then they can go on to get the brachytherapy. Because previously they'd have to do a TURP, but it's more destructive to the prostate. And so I think resume is a faster, gentler, easier way to get a prostate volume down to facilitate, in fact, some prostate cancer treatments. The last thing I would say, though, is that if someone is on active surveillance for prostate cancer, and they're going to be getting an MRI every year or two, my personal preference is to lean a bit more towards the resume because there's no foreign body. My concern is that the urolift may give a little bit of artifact in the prostate and they won't be able to see necessarily all parts of the prostate for surveillance on an MRI. So you have to consider that as well.
Dean, a great presentation. Thanks a lot. It's very well summarized, and it's very practical. As we can see, that it's more of pros and cons of each procedure. It's more of patient and physician or urologist decision. It's more of patient-informed decision. Having done both procedures or other options as well, significant part of it is like the after treatment care. So after surgical treatment care. From your experience, what's your input about from the patient that you see? I know it might be a political kind of questions, but like, how do you see, like from your own reflections about the after treatment care, which procedure you find that the patient is more likely or having less kind of complications as compared to the other, or more tolerable as compared to the other?
Yeah, it's a great question, Turkey. So, I think, first of all, the likelihood of one of these patients coming back to the hospital, say in clot retention, bleeding, is far lower, of course, than if you did a TURP, right? So serious complications are exceptionally rare and very low. I do think that with both of these, they do need a little bit of attention, you would say. And again, it depends on what system. Maybe it is a little bit more political. So for me, if they're doing it, it's private practice, not the public system. Maybe you want to give them a little bit more, customer service and care. I think that's an important thing to talk about. But usually in the first week or two, particularly the second week, is when they'll have some irritative LUTs, and you want to just encourage them that it will get better. But I don't think it requires anything more special than what you would typically do. I think there are a couple questions that come up on the chat. I thought maybe I'll just address them very quickly since people have asked. So there's a question about, is there a risk of infection with the UroLift implants? Really not, because they're placed right into the prostate. Of course, I put everybody on antibiotics for a few days after. We make sure there's a urine culture. Another question has to do with the risk of major hematuria in Resume. There really isn't any major hematuria. Dr. Rabaz asked about after Resume, when can the meds go off? So typically, if men are feeling better by around 1 month, we tell them to stop all of their medicine. And certainly by 3 months, I would expect that 95% of patients will be able to get off of their alpha blocker and their 5-ARI. There's another question here about, how do you judge the median lobe? That's a great question, and it's really subjective, honestly. For the Resume, I don't think you have to worry about judging the median lobe, but with the UroLift, again, you're going to need to be trained to do that special technique. And I think it comes with practice and your level of comfort. I don't give any medications prior to the MIST for better outcome. I don't think that's required. Anyway, I'll hand it back to the moderators, and we can go through some of these questions, or the moderators can go through the Q&A as well.
Well, thank you. So, two questions, because you mentioned the MIST are probably an alternative to medical therapy. So, how do you see that with the insurance, and is it covered in the Canada or in the States as a primary therapy instead of alternative to medication? So, can you comment on this, please?
Yeah, what I've learned about insurance is that there's no one insurance, and I don't know how it is in Saudi, but there's so many different insurance plans. It depends on your job, etc. So, some insurance plans will say you should be on a medicine first before you can go on to a MIST. Others will just, you apply and you can get it. I think as a broad discussion, the idea of the option of doing a MIST prior to medicine, in my opinion, is reasonable. Now, if an insurance company says, well, you have to go on an alpha blocker for 3 months and then fail, that's fine. You can get around through the insurance company. But I don't think that there is a rule that you have to be on a 5-ARI for 1 year prior to surgery or a miss. I don't think that's necessarily a condition of moving on.
You're offering the mist for almost all the candidates, but let's say the patient is paying for this. Which patient do you think is the best for Resume, and which patient is the best for UroLift?
Yeah, I don't think there's a huge difference between the candidate for the two. You know, what I try and do is I lay out for them the differences, and then they can choose. Now, there is an economic difference between the two. So many men will say, well, if A and B are roughly the same, but A is more expensive than B, they often just choose B. So that's just economics. That's just the world, right? So, you know, my job is not to tell men A is better than B. My job is to say, these are all the attributes of A, these are all the attributes of B. And then, you know, and you can decide. But of course, sometimes the final decision maker is the cost. But there are some differences. So, you know, the retreatment rate is slightly different. So some men, if they're 75 or 80 years old, they don't care in 5 years or 10 years what the retreatment rate is. Whereas maybe someone younger, they care more. So those are some small factors.
From your experience, which one is the most symptoms will disappear with the Resume, let's say? Is it the voiding symptom or the storage symptoms, or so which one from your experience?
So, you know, they're both going to improve voiding symptoms, right? The goal is to change the prostatic anatomy so that their flow improves. The question is, when people have a lot of storage symptoms, what percentage of them will get better from a bladder outlet surgery, and which of them will have persistent storage or overactive bladder symptoms after TURP, even, for example? And that number is probably around 40%. 40% of men after even TURP who had baseline storage OAB symptoms will have persistent symptoms. So that's an important part of counseling of patients. If someone has nocturia 5 times, frequency every hour, urgency incontinence, I would counsel them very strongly that you should do something for your prostate. It's 70, 80 mils, you have a slow flow. More than likely your storage symptoms will improve. However, there is a chance that you will have persistent overactive bladder, and you will still have to be on a beta-3 agonist or an antimuscarinic. So I think that's an important conversation to have. And that was one of my early slides about storage symptoms, voiding symptoms, and individualizing the treatment.
Dean, if you do have a patient on anticoagulants, some of the audience is questioning that questions. Do you have a preference of one procedure over the other?
So the on label is that you are supposed to stop anticoagulation for both. Okay, so it's a rare patient where you actually cannot stop their blood thinner, their Eliquis or whatever for even, you know, those 2 days. So you know, there have been bleeding complications from Resume. It's rare, very, very rare. There have definitely been bleeding complications from UroLift in the FDA database. You can look them up. There is no published literature that I'm aware of that's actually done an anticoagulated population. So my feeling is, my advice is, if you can stop anticoagulation, you should. You know, my concern is with a UroLift, if they have bleeding in the pelvis, there's nothing to compress it. So if your suture hits something bleeding on the outside of the prostate, they'll get a pelvic hematoma, and you can hold a lot of blood there. Whereas with the Resume, if they bleed, it'll all be into the urethra and they'll bleed it out, and then you can manage urethral bleeding. So if you forced me to choose one, I would probably do Resume, only because I would be worried about the very, very rare, 1 in 100,000, I don't even know the number, of a pelvic hematoma from the Urolift that I couldn't control without opening up the pelvis, right? That would be a bad complication.
Thanks.
Great. So we have some questions from the audience. So one of the questions is the prostatitis is a contraindication for one of these two procedures. So this one question, if you can answer this.
I think the prostatitis is a really interesting question. So I've personally been thinking and talking to colleagues about Resume for prostatitis. And I think it'd be a really interesting study that we're looking at because, I wonder whether the steam, the heat will actually cause some actual, you're killing the cells, you're removing them, and there may even be some heat effect on the nerves. So I could theorize that, by killing the cells with the heat, maybe in the long run, it might be a treatment for some prostatitis. For sure, their symptoms will get worse initially. For a Urolift, it doesn't really make sense because a Urolift is just mechanically opening up the prostate lobes. It's not fundamentally changing the nature of the adenoma. So I don't think Urolift makes sense for prostatitis, but I do think that the idea of Resume, water vapor treatment for prostatitis, is not yet proven, but I do think that there may be some potential there.
Excellent. So I have a lot of questions regarding the injection of Resume. So is it, I know you do it, you do mapping and you calculate the distance and you give it based on the prostate size, but always there's sometimes one or two more injections more. So you tend to give more or less?
That is a wonderful question. So, there are two camps. There are people who say more is more and less is more. And I don't know if we know the answer for sure. I can tell you that over treating the prostate is probably not good. In fact, it's not good. You will get too much inflammation, too much necrosis. You can only kill a tissue once. A cell can only die once. You can't double or triple kill it. And I think what you're going to end up seeing is a lot more dysuria, sloughing of tissue, retention. So I don't think overtreating is necessary. It makes no sense to do all 15 treatments in every single prostate. There are some exceptions. My personal opinion is that patients who are in retention, for example, I would tend to give them a little more than as opposed to a little less. The reason is because I'm going to wait for that prostate to shrink down about 50%. So they're going to have a catheter in anyway for at least a month. So there's one published report that came out in the last 6 months showing that you can do Resume for retention, and it's around 65-70% successful. So I think that's a great option. Urolift has also had data that shows it works for retention as well, to be fair. I think that the answer is do the right number. Don't undertreat, don't overtreat. Try and get it just right. If you add one or two more, I don't think it's the end of the world, but really going overboard, I think you start to get more problems than improvements.
So this answers a question regarding the patient with acute retention. I think it's not contraindication, as you mentioned. That moves us to a question from Dr. Othman is, how would you place aquablation among the both procedures? Is it a step up compared to these two procedures, or what do you think?
So I think that's a great question. I purposely didn't include slides on aquablation. I could have lectured for 3 hours on aquablation, but so for those who don't know, aquablation is a new surgical technique approved by the FDA in the United States, Europe, Canada. I have an aquablation machine. This is ultrasound guided, so real-time ultrasound guided, transurethral, robotically executed water jet ablation. The big difference is that this is not a minimally invasive treatment. It still has to be performed in an operating room under spinal anesthetic or general anesthetic. It's a transurethral surgery. You need to have the ability to do electrocautery at the end of the case, place a catheter. Patients usually still stay at least one night. We're trying to get them out day surgery. So they're not in the same category. I think aquablation has its own attributes that probably make it better than TURP or laser or those more surgical techniques, but they're really not comparable to a mist, Resume, or UroLift, which is why I didn't include it. Where I think aquablation really fits in is it treats the full range of prostate sizes from 30 to 300. It's a volume independent technique, meaning as the prostate size increases, it doesn't really increase the amount of time to do a procedure. So to do an 80-gram prostate and a 180-gram prostate probably only adds 2.5 to 3 minutes procedural time. So that's very important. So I do my average prostate size for aquablation is about 170 mils, very, very big, because that's where I think it really shines, but it can be for a wide range. But it's different, which is why I didn't really include it. But I do think when you're talking about BPH as a field, I think the introduction of robotics, water jet ablation, ultrasound guidance that aquablation brings will actually change the field significantly, but it's not a minimally invasive therapy.
So I have a question from the audience. Is what's your definition for failure for Resume? So when you give a second session, this is one question. And if you have a large prostate, do you prefer to use 2 guns, 1 spot, or you do stage therapy?
So, so my feeling is that I would rather do stage therapy if I was to do it. I haven't had to do it, but I've thought about it. If I had such a huge prostate, 150, 200, you know, you could either do left side, right side and have it open up a little bit and then go back 6 months or 12 months later and do more. You could, in theory, do a hemi-ablation. You know, we've all done TURPs of just one enormous lobe and left and said, maybe this is enough, right? So you could do that and then decide to go back later. Maybe you won't need to do anything else. But no one has ever studied this. No one's ever studied, you know, 180-gram prostate and do all 15 injections on just one lobe and see if you can get a hemi-cavitation. Very interesting to consider. When would I consider failure? Well, first, I think you need to give them a minimum of 6 months, maybe even 12 months. I would look back inside and I would say, okay, well, what is a failure? Do they still have prostate tissue causing obstruction with objective findings, a slow flow, high residual? Or is failure that their IPSS score is still high, but when you look at it, it's high because of frequency, urgency, nocturia storage symptoms, and you have inadequately treated their overactive bladder. So I've had a few patients who are, say, my flow is amazing, but I'm still disappointed that I'm going so many times in the day. And when you look back at their baseline, they had storage symptoms significantly. So you have to be able to shift a little bit in this area of male LUTs and remember that that includes the bladder. So failure, it depends on failure.
Right, thank you.
Okay, yeah.
So go ahead, Prof.
Very good. Just a quick one. Now, you have in your center aquablation, you have TUR, you have UroLift, you have Resume. Let's think back about the last 50, 100 case of yours. Can you tell us approximately how many TUR, how many UroLift, how many aquablation, or can you answer that question?
Yeah, I think, so let's say in 2019, right, for the last year, probably did 120 Resume, 100 green light laser, 20 aquablation, 2 TURP, and maybe 20 UroLift.
Wow.
So I think, you know,
You could choose between the similar procedure like the Resume, UroLift, TR. What make you choose this over the other?
Yeah, you know, it really gets into that conversation about expectations, values, What's patient preference? I mean, obviously every country has different influences. So for me, for example, some of these surgeries are covered in the public system, the patient doesn't pay. Some of them are private, so that's always a factor. Some patients want treatment sooner, so they choose the thing that they can get done faster. Some people are on anticoagulants, and I want to do a laser, for example. Some men have enormous prostates, and I want to just do the aquablation. So there are small factors, you know, here and there that decide, but they're usually not because of a deficit of the technology. They're more to do with patient factors, hospital factors, healthcare system factors, right? They're other things.
Okay. Dr. Turky, you like to look at some questions from the audience, and you know, because there's so many questions from them.
Yeah, there's a lot of questions already being mentioned actually during the presentation. And some of the main questions, like what's the applications of Resume in prostate cancer? I mean, although it might be a completely different talk, it's more with theoretical things. But if you do have anything to comment on Resume, or particularly Resume in low-grade prostate cancer implications.
So a very interesting thing is the company that invented Resume has a new spin-off company called Francis Medical, and they are actually creating a brand new product that uses the technology of Resume to treat prostate cancer. So that's in early phases. I will say that, remember that the heat, the steam will stay in the zonal anatomy. So if the majority of prostate cancers are in the peripheral zone and you treat the transition zone, you're not going to kill prostate cancer cells. If you happen to have an MRI that shows that you have a prostate cancer in the transition zone uniquely, and you end up doing a Resume, you know, for BPH, but you target that cell, and if you could obviously do a follow-up MRI, and if that zone happens to be treated, that's great. But it, of course, is not approved for the treatment of prostate cancer. I would make that very clear.
If you do Resume near the vario, would the patient develop incontinence?
If you inject steam into the external urinary sphincter, you'll damage the sphincter and you can develop incontinence for sure. So the idea is that.
How far from the vario would you stop, the last one?
I would stop in line, parallel to the viru.
I see, okay.
Of course, if you have extending, remember that the steam will go almost in 360 degrees. It'll go forward, it'll go back, it'll go up, it'll go down, it'll go in. So some of it will go behind you to get some of that apical tissue. So I don't think you need to worry too much about it.
Okay, guys, any
just regarding the learning curve from the audience, I think it's a pretty easy procedure. So can you comment on both Resume and your left? Let's take it as the last questions of.
Yeah, I think that the learning curve is very approachable for both. I think that the three-dimensional planning of both is what takes the skill. I think with the UroLift, your hand technique and how you pull the various pulleys and triggers is very important. And if you don't do that right, it will not work. And if you don't compress the tissue, it will not work. I think the Resume is a little bit more foolproof almost, because as long as you put the needle in the right spot, generally the steam will do its work for you. So I really think that the Resume, after, like I said, 4 to 6 cases, I think you're really comfortable. Maybe UroLift is 6 to 15 cases, a little bit more. Of course, these are straightforward 30 to 50 milliliter prostates, no median lobe. You know, we're not talking about tricky anatomy or large median lobes or what have you. The other thing we didn't talk about is for, regrowth. If someone's had a previous TURP and they have some very focal regrowth, instead of going back to do a second TURP, something like a minimally invasive therapy where you could put in a suture or steam just that one lobe that's regrown is very useful as well. It's another application.
Okay. Any more questions, guys? Or okay, one more question is not related to this. As I understood, you are a member of the CUA guidelines for the prostate. Am I correct? Okay.
Yes. Yeah.
And it's written there, according to CUA, we recommend that PAE, the prostate art, should not be offered at this time for the treatment of LUTS. Is this still valid? Because there was debate in the SUA recently about a talk. We talked to our colleagues in the radiology because they are advocating this procedure. So, what is the stand of the CUA now on the PAE?
So I can only speak to myself. I can't speak on behalf of the Canadian Urological Association. All I can say is that in 2018, when we redid the guidelines, we felt that the level of evidence in the published literature was insufficient to recommend PAE as a standard treatment for BPH. That being said, I mean, I think more centers are doing PAE. My center does PAE. So it's me, a urologist with an interventional radiologist, and we have now a program. I have a few problems with PAE. So number one, an interventional radiologist does not understand LUTS, BPH, storage versus voiding symptoms. They're technicians. And I think there is a problem if patients are getting referred directly to a radiologist to get a PAE, because they have not done a DRE. They have not assessed whether it's overactive bladder, storage symptoms. They don't know the very subtle findings of a urethral stricture versus BPH. And so they really don't have the content expertise for as a urologist does. So I think we as a group of urologists need to keep male LUTS and male urinary symptoms within us. Now, if you choose to collaborate, and the collaboration is that the urologist remains the gatekeeper, then I think that's fine. PAE itself, there's some good evidence for it. There's some not good evidence for it. It always amazes me. We've done 100 of them at least. Some men do great. Their symptoms are improved. Their prostate shrink down 30%. Some men's symptoms improve, but their prostates don't even change at all. And that's really peculiar. And then some men, it's as if nothing happened. And so I don't think you can get as a consistent outcome with PAE as you do with anything that we do in urology, whether it's minimally invasive or transurethral. So that's, I think, the problem with giving it in a guideline is that number one is not performed by us. And number two, I don't think the results hold up to the highest standards that we're used to with our therapies. So perhaps when these guidelines are revisited every 5 years or so, that will change as more evidence comes out. But I do have my concerns. But of course, we've had men who have great outcomes and they're too sick for surgery. Their prostates are 280 mils. We're very happy to send them to the radiologist.
Dean, brother, thank you very much. It was a great presentation, very practical. We have learned a lot through some major practical points, tip and tricks for someone who has a huge experience of different procedures that you didn't see that much, actually, that many times. It's good to have you. We're very pleased to have you. It's a privilege to have you again, brother. And we thank all the moderators, Adel Ammari for organizing the great webinar, as usual. He's a tech guy. And we thank all the audience and for their comments. And we apologize for not being able to answer all of these questions, but I'm sure Dean will have maybe another 2 to 3 hours of extended presentation to cover all of these talks. Dean, thank you. Thank you very much, brother. Thank you.
Thank you. It's a great pleasure. And I hope that that in the not too distant future, I'll have the great pleasure of being back with you in person in KSA for us to do cases and to see each other as friends. So I wish you all the best, and thank you very much for having me. It's a great honor. Thank you.
Thank you. Thanks a lot. Have a great night.